Welcome to AETCM. Today we're going to discuss a case about a 73-year-old female who was brought into our ER with complaints of breathlessness for the past 2 days associated with bilateral lower limb edema for the past 1 week. Shall we begin, sir?
Yes.
Sir, initial assessment, patient was conscious, oriented, able to complete one full sentence. Coming to airway was patent, no secretions were noted. In breathing, air entry was bilaterally equal, saturation of 96% maintained in room air, and respiratory rate of 18 per minute. In circulation, BP of 160 over 80 mm Hg with a pulse rate of 65 per minute. All peripheral pulses were palpable. And in disability, GCS score was full and pupil was bilaterally equal. In exposure was done. A patient was covered to prevent hypothermia. Coming to adjuncts, ABG showed metabolic acidosis with pH of 7.29 and bicarb of 17.1. So, sir, and ABG was showing an HB of 24.1 with creatinine of 2.32 and all other within normal limits. And ECG was also taken, sir. ECG was showing Q waves in V1 to V4 and 2-3 AVF.
Okay. What is a significant Q wave? Significant. You see a lot of Q waves in emergency room, ECG. What do you mean by a significant Q wave?
More than 5 small box.
More than 25% of the following QRS complex. Means if QRS complex is 10 squares, it has to be more than 2.5 divisions. And that too, it has to be at least 2 consecutive leads. Lead 3 you are getting, lead 2 or lead AVF has to be there. Then only it will become a significant Q wave. And if you are getting a Q wave in lead 3, what else you have to do? You have to ask for a deep inspiration ECG repeat. And if it is reversing, it's a normal phenomenon. If it is not reversing, then it is a significant Q wave. So is it a significant Q wave according to your...
Yes, sir. It was a significant Q wave, and on further evaluation, we found that outside they came from another hospital, and the ECG from that hospital was showing ST elevations in V2 to V5 with 2-3 AF elevations, and was diagnosed with an anti-revolve MI.
Okay. Yeah. Evolved anti-revolve.
Evolved anti-revolve MI. Her history is that she was a known case of hypertension, diabetes, came with complaints of bilateral lower limb edema with the past 1 week with breathlessness for the 2 days. But there was no history of any fever, chest pain, sweating, no decreased urine output, no history of any pain over the lower limbs, no history of any trauma. But and for the same complaint, went to a nearby hospital and evaluated and found to have raised HB with altered renal functions and leukocytosis. And treated with antibiotic for the raised leukocyte counts, and for the HB part she was referred to a hospital for the further management. And on further there was no allergic history, and in general examination she was a thin built lady and moderately nourished. Bilateral pedal edema was noted, and JVP was also elevated. Pulse rate of 70 per minute and BP of 150 over 80 mm Hg, saturation maintained 97% and respiratory rate of 18 per minute. In systemic examination, respiratory system air entry was bilaterally equal, bilateral basal crepes were noted, and GIT splenomegaly was noted, and CVS S1 S2 were had, and CNS there was no focal neurological deficit noted. And sir, on further we also did the lab investigation, which showed total count of 16,000 with RBC of 9 lakh and HB of 22.6.
What is the hematocrit value?
Hematocrit was 71.
71.
HB how much?
22.6, sir. And we are suspecting polycythemia picture with an evolved MI, sir.
Okay.
Yeah. And further for the
Your
creatinine was also elevated.
How do you what do you think that polycythemia is there? Creatinine is elevated. MI is a part of polycythemia. Why MI develops in polycythemia?
Due to blood being
highly viscous.
highly viscous, which
Highly viscous.
hyperviscosity will cause.
It can produce blocks in the blood vessels wherever it is stroke, myocardial infarction, peripheral arterial disease. But creatinine is elevated. What do you think? What are the reasons for creatinine elevation, and how do it produce problem in your management?
Can cause again renal infarction, sir.
It can produce a renal infarction and produce elevated creatinine.
This one.
What else? What else you think? Renal infarction, everyone tell MBBS.
This renal stenosis.
You told renal infarction, renal stenosis, everything. What else you think? Can be a renal malignancy.
The next is
One of the cause for polycythemia is kidney tumors. So that itself can elevate creatinine. Okay, so you have to evaluate that also, whether you are admitting doctor. Okay. So creatinine elevation is a big problem here because we will not be able to do contrast studies, all these things. Okay.
And for the lady, other than that, she was fine as such, and we started her on heparin infusion for the evolved heparin sub-Q 5000 units sub-Q were given for anterior MI, and also further lab investigation including JAK2 mutations was also given.
In an emergency room, in a polycythemia case, whether it is myocardial infarction, stroke, what will be our strategy? Heparin is okay. Will heparin be helpful in polycythemia to prevent the thrombus?
No, we have to give fluid correction.
It is not due to the platelet or fibrin which producing block. It is due to the RBC, which is highly the number of RBCs in the blood is very high. That's why he is developing problem. So how do you treat that?
Hydration.
One is hydration. If there is no cardiac failure, better to hydrate the patient well. Second thing, venous section. These are the two things we have to do in emergency room. You do water, you remove RBCs, phlebotomy, and remove around 500 ml. Patient clinical condition may improve. Okay. Heparin will definitely be indicated because you are treating a myocardial infarction. But you should understand why that myocardial infarction has occurred. That is due to the polycythemia. Okay.
No, she was started on fluids and followed by later on
This
phlebotomy.
patient has got pedal edema, elevated JVP. How do you know that we can give fluids?
Echo.
Echo is one thing.
IVC.
IVC has to be checked. Echo has to be done. What is the echo finding? Is there any cardiac failure?
No, echo showed no regional wall abnormality, good LV, dilated right atrium, left atrium, mild dilation was there.
Elevated?
No,
No elevation of right atrium pressure and left atrial pressure.
no, ejection fraction of 60%.
Why she is having elevated JVP then? Is there any reason for that, or you are made a mistake, like JVP is not elevated? Falsely elevated JVP. If at all there is an elevated JVP, your ejection fraction is good, what do you suspect in a polycythemia case?
Not superior gonna cover that thing, sir.
thrombus below that level.
Below esophagus vein, above esophagus.
Thrombus superior gonna cover and all of that.
If there is a block there, what will be the type of JVP elevation?
Continuous. It will not vary. with
It will be a non-pulsatile JVP. But what else you suspect? Somebody is having polycythemia, elevated JVP, pedal edema. What else you suspect? More common things. Pulmonary embolism. Chronic pulmonary embolism has to be thing. Because there is no LV failure. Why should patient develops RV failure in a polycythemia? It is due to chronic pulmonary embolism. Okay. It cannot be acute because your patient is not symptomatic in that sense. So we have to be very careful. Okay. Either you have made a mistake and JVP is not elevated, or if there is JVP elevation, you have to suspect other things. If there is a non-pulsatile JVP, it is a IVC obstruction. If pulsatile JVP is there, then you have to suspect chronic pulmonary embolism. Okay.
And further, we started with the hydration, and also phlebotomy was later on done, sir.
Phlebotomy should be done in emergency room itself because you are seeing somebody is having an emergency like myocardial infarction. It has to be initiated from our side.
Okay, sir. And later on, she was sent with the investigation for the cause for the polycythemia.
How do you investigate polycythemia? It is not our duty. It is not done. Should not be done from emergency room. But we should know how to investigate because some patients will be admitting in ICU.
First, we'll have to rule out the possible physiological causes of polycythemia. Like most important cause is asking the patient for smoking history because it is most commonly seen in smokers.
Okay.
So once that is ruled out, then we ask if the patient his location that again high altitude areas because of chronic hypoxia, patient will have a physiological increase in the RBCs leading to polycythemia. So once the common causes are ruled out is when we think of the genetic causes. The genetic causes, then malignancies have to be looked into as a paraneoplastic syndrome or some kidney tumors.
Paraneoplastic syndrome can be there in elderly individual like 70 years.
Or if there's any, again, certain bone marrow malignancies, again, before they go into depletion state, they'll have a hyperactivity. So that also has to be looked into. And when it comes to genetic causes, most common would be a JAK2 mutation. Is once all of this is screened out, is when we go for genetic mutation asked for.
Erythropoietin levels in all these conditions.
Erythropoietin levels will be high in
Primary or secondary?
in
Primary what happens? Secondary what happens?
In secondary, it will be high.
Secondary.
Secondary
it will be
erythropoietin.
high. Especially COPD and all.
It will be high. But in primary, again,
The secondary
it will
to
be,
some-
yeah.
Okay. JAK2 mutation should
JAK2
be sent.
mutation.
Okay. Sir, anything regarding anesthesia?
So what is the age of the term?
73-year-old
So
female.
these
sir.
patients are, you are planning for an RSI. So how will you proceed with? There's an indication you are deciding for. See, what are all the angles you will look into? What medications?
RSI. What will you decide?
So, regardless of if the patient state, again, hypoxia has to be looked into, so patient has to be properly pre-oxygenated.
Okay.
And then once for 3 minutes, adequate pre-oxygenation with 100% FiO2 is given, or rather high flow oxygen is given. We prepare for RSI. Basically, no much changes with the as we intubate the regular patient, a polycythemia patient can also be intubated. But their adequate
So
hydration.
airway changes in the old age. Geriatric patient. What are
And
the
then dentures.
dentures? Okay.
Anatomical
loose teeth
inspection,
Or dentures,
yeah.
removable or fixed dentures.
They'll have less of apnea time.
Pardon ma?
Apnea time will be less,
Apnea time.
so more prone to hypoxia.
Okay.
Then fragile mucosas, so increased chances of bleeding even with trivial trauma. Then loose teeth, yeah.
A difficulty in
Neck movement. So cervical spine.
difficulty will be there because spondylosis and all that.
Spondylotic changes, so neck movement will be there. And
Difficulty in
because
ambulation,
you don't
dental
suppose the
respiration.
patient is having denture. How will you ventilate? How will you intubate?
Take the dentures out.
During ambu, we keep the dentures and before intubation, remove the.
Ventilate with the denture, intubate without denture. Remove it, or else it may be dislodged and go and cause a foreign body obstruction. You told there may be oxygen saturation drop. How will you overcome?
Again,
One
with
is
adequate
pre-oxygenation.
and quick intubation.
Pardon?
Early intubation.
And what is nasal insufflation oxygen technique?
We keep a nasal prongs with that during ambu and also during intubation also. So basically,
Pre-oxygenation itself, along with that we can continue.
so-
And throughout the
throughout the process, again, throughout the procedure, we keep a nasal prongs with high flow too.
high flow out, that is more important. So the patient is paralyzed. How it helps?
Thing is actually, even if paralyzed, there is some amount of going into that.
See again from a higher concentration to lower concentration. Diffusion. See the high amount of oxygen that is in the nasal and oral cavity will be diffusing up to the alveoli and then further also into the alveoli. So we can enrich that way. Okay. And then drug selection in this patient.
Drug selection was because of polycythemia. We'll have to first rule out any hemolysis. Hemolysis again can cause hyperkalemia, and if patient has hyperkalemia, then succinylcholine cannot be given. So once potassium electrolytes are fine, then succinylcholine also can be given.
Creatinine for this patient was elevated.
Elevated.
So potassium level we did not discuss.
Yeah.
Potassium, there is a high chance of error in potassium when you are taking the lab sample. That we have to be very careful. Hyperkalemia, false hyperkalemia is very, very common in this condition.
So preferably avoiding succinylcholine would be a safer option.
Okay.
And we can go with, if the patient, then depends on the patient's hemodynamic status. If patient has hypotension or bradycardia, then in
For
that
this
case,
patient.
for this patient is hemodynamically stable. So in that case, either etomidate, ketamine can be given as an induction agent.
See, was there any medication history taken during was she on any?
Hypertension, the OHS and
See, what is the drug treatment for the hypertension she is on?
he was on
Any beta blockers? She told
Normally
the pulse
beta
rate.
blockers are given. So
Pulse rate you told, what was the pulse rate? Around 60,
70.
70. So this is more important. See, otherwise during the process also the patient may go for still further bradycardia. So we should keep atropine or any agent that would. See, which is the drug of choice for beta blocker bradycardia treatment?
Glucagon. Glucagon.
Any other options? Atropine will help.
Not when
Atropine will not
doesn't
help.
help.
Isoprenylene. Intravenous we can give. Okay. Then the succinylcholine is avoided. The other alternative is
Rocuronium is there. Atracurium would be better because it is Hoffman's degradation, so there will be no involvement of the other organs.
rocuronium.
Atracurium, sir.
Atracurium. Okay. See, but it is not an agent for RSA. RSA agent should have an onset within 60
So
seconds.
rocuronium, vecuronium.
But other rocuronium we can give it. Okay. Number 2, the agent, induction agents.
Etomidate.
Pardon?
Etomidate, sir.
Etomidate. Okay. We can give etomidate alone.
Along with some pre-treatment fender.
What?
Analgesic.
Fentanyl, most important. Etomidate is not having any analgesia. So sympathetic system stimulation or parasympathetic, that was stress response, we can't abolish only with etomidate. So adequate analgesia, that's fentanyl. You have to give. And next.
Then ketamine can be given.
Pardon?
Ketamine propofol can be given, sir.
Ketamine, okay. Ketamine we can give. BP is normal and slightly high also. Propofol, what is the main disadvantage in propofol?
Sudden hypertension.
Hypotension. What will happen in an old age?
More prone. More prone for hypotension.
Pardon?
More prone for hypotension.
When
So
once
that
hypotension is coming, natural mechanism will not act.
kick in.
Vasoconstriction part will not be active.
More dilatation.
One already patient is on beta blocker. Number 2, atherosclerotic changes in the vessels, vascularity. So vasoconstriction effect will not be achieved. So we should be very careful in administering agents which will cause hypotension. And she may be already on any anti-hypertensive drugs also. So both will have synergistic action. Profound fall may occur. Okay. So etomidate with fentanyl, a good choice. So only problem with the ketamine is it's already 150 something, systolic pressure. People will be slightly elevated and old age people. So we have to be very careful.
what are the other problems of polycythemia other than what we discussed?
can cause bleeding disorders,
Bleeding can occur. But
visual disorders,
sudden loss of vision can occur.
CNS manifocal neurological deficiency.
That all part of thromboembolism. Other than thromboembolism, all are thromboembolic features.
Head
Skin.
Either pruritus.
Pruritus. Severe itching will be there. Erythromelalgia. Redness, itching. How do you treat that conditions? Antihistamines, aspirin. Okay, these are 2 drugs can be given. And JAK2 inhibitor, rituximab. Not rituximab, rituximab. Okay, that can be given. Okay, but that is not our duty, but we have to only treat the emergencies. Most of the emergencies are due to thromboembolic phenomenon. You have to hydrate the patient well. That is the best treatment. And if possible, remove the blood. Okay, no need to wait for anyone. You can remove the blood. Okay, just remove 500 ml. Patient clinically improve. His cardiac failure will improve. His stroke part will improve. Everything will improve. Here, the myocardial infarction is only due to the polycythemia, mostly. What else you want to talk about?
So basically, if a patient like is undiagnosed case, will be presenting most probably the secondary like a complication of polycythemia, like a thromboembolic episode could be a CV, MI, DVT, pulmonary embolism, whichever be this thing. The first clue will be like to if you are seeing elevated HB in the initial evaluation, we have to think about polycythemia. So the cutoff will be 16.5 gram in men and 16 in women. And so the hematocrit actually 49% in men and above 18 in women, we had suspect polycythemia. And also this
But in
polycythemia,
emergency room, suppose somebody come with high hemoglobin percentage, hematocrit. What other causes you suspect?
yeah,
Emergency room.
so this polycythemia can be relative or absolute.
Yes,
So relative can be most probably secondary to dehydration. So there won't be any actual
Dehydration, trauma.
blood.
Initially, it will be hemoconcentration. Then you get hemodilution.
So basically, polycythemia means there's increased cell mass in the or increased RBC in the like circulating system. So it could be relative secondary to dehydration or maybe absolute because of actual increase in RBC. So if it is secondary, we can improve the patient by hydrating it properly. And because if it is primary, then we have to think about the actual cause and then evaluate. The cause again can be primary and secondary. Primary will be like secondary to like any genetic mutation like JAK2 mutation, and secondary will be secondary to a tumor like in the bone marrow or maybe in the kidneys causing excess erythropoietin, which again stimulates the bone marrow to create more RBC. So depending on the treatment, we have to treat accordingly, start our management and treat. But as far as emergency medicine is concerned, we have to initial management will be like to assess the ABCs, stabilize the patient, then initiate dehydration and as early as possible, and also phlebotomy if required. And also, if coming with a complication like any thromboembolic episode, we have to like start on either anticoagulation or also antiplatelets can be added in ED itself. So further care of management, and also to like. So further evaluation of this thromboembolic episode, we have to like thoroughly evaluate the patient from head to toe for any like complication. Even the patient is coming with only MI, there is actually a very good possibility that he could develop later certain other sequelae like DVT, stroke, and all that. So which need to be continuously properly evaluated during admission also. And the main treatment, mainstay in ED will be like hydration and phlebotomy only.
So in this patient, already the patient is having renal problem. And also suspected congestive heart failure also.
Congestive heart failure is not that, no? Echo does not show.
No.
Echo is normal.
Echo is normal.
Clinically, some
Only
JVPs.
Only jugular
JVP
venous
is
distance.
Mostly that is a wrong clinical.
Okay.
I don't think it is there.
So when there is a renal failure or renal insufficiency, fluid overload we have to be avoided. So if at all you want to give the fluids, you can have a central venous pressure monitoring along with that, if we can go. But number 2 is the dehydration he told. So dehydration, hemoglobin increase may not be there, pure dehydration alone. Or the RBC, the count also will not be that much, that will be in the normal limit. So that time, otherwise the renal problem and other problems are not that we can hydrate. But in this particular case,
there is actually one more newer guideline.
dilution, you have to be very guarded, we have to do it.
A newer
RS venesection is an ideal.
There's also a newer technique actually using ultrasound called Vexus protocol,
Okay.
which actually we try think about we assess 4 areas. One is IVC, like we usually do, and also we assess the hepatic veins for any congestion. If anything above 2 centimeter of IVC, we have to look for this further downwards. That is actually to rule out renal vein congestion. So basically, if it is actually on the higher side, we have to avoid giving fluids because it can again worsen the renal parameters. So we assess 4 areas. One is IVC, then hepatic veins, then the veins, this portal vein, and also the veins going to the kidneys on the right side. If the 4 areas, if anything is coming as with a value of +1, we have to like judiciously give fluid depending on the pros and cons. Okay. But if the parameters are negative, then we can safely give fluids. Yeah. There is actually a Vexus protocol that's based on this USG guided fluid management.
That's a guarded.
It's like a newer this thing. Yeah, yes. So this patient actually IVC was like mid dilated, like so we gave fluids like that. But the
So
issue
suppose
is,
we are
uh,
taking the blood from the patient.
mm,
Can you use it for blood donation?
no,
No. Why?
it's a mutation,
It can be pre-malignant.
pre-malignant.
That's why it is not recommended for blood transfusion.
So actually, we have to pay to the blood bank to bleed the blood.
Mm.
Directly in ER, we can remove the blood and discard it.
Mm-hmm.
Blood bank request is given only when you want to preserve the blood.
Mm-hmm.
To discard, we have to just discard according to the normal protocols. Which how do we discard other things, other body material? That like that only we discard.
Bio waste.
Bio waste. Okay, sir.
Okay, sir.
Thank you.
Okay, thank you.